This is the second in a series of national health reform forums that we're convening here from the ANU to look at key questions around health reform arising from the various reviews that the government has commissioned. This, we had one on workforce in December last year, and this one is around GP super clinics. You might ask why we're looking at GP super clinics. Well, first of all, to lead into the key reform area of primary health care, but also it's one of the few areas of reform that this government has actually initiated and moved on since it was elected in 2007. So, and clearly it's an area to which they're committed, possibly to further development. So we're focusing this primary healthcare discussion initially around GP super clinics and asking the question, are they the answer to what they might be the answer we haven't defined? And you might be able to help us do that. We brought together for today an expert panel who can give views and information about these reforms and about their possible implications for the health system as a whole. Immediately to my right is Professor Mark Harris, who's a distinguished researcher in the areas of access and quality and is Executive Director of the Centre for Healthcare and Equity at the University of New South Wales. Dr. Steve Hambleton, to his right, is the Federal Vice President of the Australian Medical Association and is a practicing general practitioner from Queensland. Further to his right is Dr. Rashmi Sharma, who's again a practicing GP and is President of the ACT Division of General Practice. And to her right is Mr. Russell McGowan, who's the Consumer Commissioner for the Australian Commission on Safety, Quality and Healthcare, and has been active in consumer health issues since the 1990s. So we have a panel here with perspectives from different aspects of the health system. The format will be each of these speakers will talk on the topic. Then it's open for questions and discussion from the audience. And also our audience includes an online audience, and we'll be taking questions from the online audience, which Martin will be handling over there. So we're looking forward to a lively discussion. The event will go till 11 AM and then we'll have refreshments in the foyer, an opportunity for those here to engage in further discussion. So without further ado, I'll hand over to Mark Harris to lead the discussion.
Thanks very much, Bob. Well, are super clinics the answer to access problems? I'd like to say a few words about what problems, first of all, they might be addressing, and then to talk a little bit about what we know from some of the research that we and others have done that might help us to understand whether they are capable of doing that, and also to talk a little bit about what we don't know. So, what evidence is there that we have access problems to primary healthcare in Australia? First of all, I think there's relatively little evidence that we've got major problems outside of remote Australia in terms of access to episodic primary medical care. Over 80% of Australians see a GP each year, and the average number of consultations is at least 5 MBS subsidised visits. And around 80% of those visits are reimbursed totally through Medicare. So the problem in terms of access relative to other countries is to episodic primary medical care is, I think, a less serious problem, with the exception of rural and remote areas, obviously. And I think the major problem that we have in Australia in terms of primary medical care in particular, and to a lesser extent primary nursing care, is in terms of availability, particularly in time, so the time it takes to receive an appointment, and availability after hours. And this is reflected in the inter-country comparative studies that have been conducted by bodies such as the Commonwealth Fund, where our performance in terms of particularly after hours availability is much less than other comparable countries, such as European countries such as the Netherlands. Where I think we do have a major problem in terms of both availability and affordability is in access to primary allied health. Currently, under the MBS-funded allied health items, which are very restricted and available to patients who have various sorts of care plans that are drawn up in general practice, about half those services are funded totally through Medicare, and about half are not. And the average fee per service for the ones that aren't reimbursed directly to Medicare is $37, and there's evidence that that's a significant barrier to access, particularly by low socioeconomic groups. So this is one of the major access problems, access to multidisciplinary care that we have in our system, in which the primary healthcare reforms, including the super clinics, are meant to address. I think also there's increasing evidence that consumers face increasing co-payments, not so much with primary medical care, but with not only allied health care, but secondary services. The alternative being that people use state-funded primary allied health services, which are available free, but the access problem being often long waiting times. For example, in New South Wales, if you haven't been admitted to hospital or are at high risk of being admitted to hospital, the waiting times for some allied health services can be up to 6 months. So, super clinics or integrated primary care centres are seen as a potential solution to this problem. The primary healthcare strategy states that these are addressing problems in terms of disparities in access, in both not only in relation to rurality, but also in terms of particular subgroups of the population, low socioeconomic groups, people with low health literacy skills in terms of navigating the system and making transitions between different services. And it sees a solution, the draft primary healthcare strategy seems a solution in patients having improved convenience of access to services, including co-located services where patients with multiple problems can see different kinds of services. And it envisages one-stop shops offering a wide range of services or smaller enhancements to private general practice, so some alternative models. The National Health and Hospitals Reform Commission was a little less specific in terms of the sorts of models of integrated primary care, but it saw again them addressing problems of access to comprehensive multidisciplinary care rather than episodic primary medical care, which, as I mentioned, is relatively well catered for in our current system, with the exception of remote and rural areas. But it sees so access to this multidisciplinary range of services being through the widespread establishment of comprehensive primary healthcare centres and services, and that these might include specialist services as well. So it's saying it saw the potential for something that provided perhaps secondary services as well. So what do we know from our research about this? I want to make 3 real observations. The first is that we have pretty good evidence from our own research in Australia that multidisciplinary care, team care, is more effective in terms of improving access to quality care and allied health care in particular when staff are co-located. It's more difficult when staff are in different organisational structures. They've got to cross service boundaries and where they are not co-located. And we've got reasonably good evidence to support that. However, on the other hand, our research, and this is similar research in the UK and Canada, confirms that size matters. That once primary healthcare services become very large, and here I'm talking about more than about 20 full-time equivalent staff, that those services are less likely to be able to offer the kind of quality of care that consumers want, particularly in terms of continuity of care and in terms of their patient-centred care. So that's a major problem, and we have to think about that when we think about just what kind of super clinics, particularly when we're talking about super clinics or integrated primary care centres in urban areas where there's a potential for them to be quite large. And certainly the National Health and Hospitals Reform Commission saw them being quite large. We recently conducted a systematic review with AFCRI and looking at models of integrated primary care across a number of countries in Canada, UK, US, New Zealand and Australia. And we found that there was a variety of models, including ones where services were totally co-located and others where there was a kind of hub and spoke model of a hub of services and some associated smaller services. We also found a range of models in terms of governance, particularly two particular sorts of models, those that were professionally led and those that were community governed or community accountable. And they're really, we weren't really able to make, from the review of the literature, we weren't able to make firm conclusions about which of those were more effective. There was a greater number of studies showing that the community accountable models had greater impact on access. However, the majority of those studies were from the US, and where the comparative groups, the comparative services were had considerably less access, and they were many of them were specifically targeting low socioeconomic groups in the US that didn't have access, for example, through their Medicare and Medicaid programs. So that's an area where we're not able to draw firm conclusions, but I think some of the key unanswered questions include what's the optimal governance model. Another unanswered question, I think, is how consumers perceive these services. We have some evidence that consumers are interested in a more one-stop shop type approach, but whether they'll see that these services, as they're established, are actually able to deliver better access and also, in particular, better at least maintain continuity and patient-centred care is a really unanswered question. The other issue is what impact these services have in terms of out-of-pocket expenses of patients. Again, that's something that we should be able to answer as these centres are rolled out. And in particular, the relative effectiveness of hub and spoke versus fully co-located models. So I think, in summary, there's probably more that we don't know about the answer to this question. Our super clinics, the answer to the access problem, than we know. There's certainly a problem in terms of access to multidisciplinary care, particularly allied health care, and that we need to address. And I think what we need to do is to research more carefully whether whether the super clinics are actually able to deliver this. Thank you.
Thank you, Mark.
Thank you very much, and I would like to thank my colleague for setting the scene. And certainly I agree with him that our health system does provide very good quality healthcare, and access in general to our health system is quite good. And those areas that you detailed are actually key areas that we do need to look at what are the solutions for the future, and GP super clinics the answer to the access problem. I guess from the AMA perspective, we would probably quickly say no, and then probably qualified yes, perhaps with some modification. And we've got to look at how we got here, I suppose. We've had a bit of a roundup of what's happening on the ground. There's been probably an underinvestment in healthcare in this country for quite a long time through quite a number of governments, in that when I trained as a general practitioner, in the 1980s, we were training 800 general practitioners every year, and a particular health minister took the view around about that time that every doctor costs his wages plus whatever he can refer to, so if we cut down the number of doctors, we'll cut down the number of the health expense. I suppose at the same time we had a public hospital sector that was learning about just-in-time mentality, in that you need to utilise your infrastructure to the maximum level, and that if we had 99% occupancy in our hospital system, surely that's more efficient. And I think we've learned since then that both of those plans and programs have actually led us to where we are today. So the access isn't too bad, but it's not all that good when you're trying to get to the front door of the hospital system, where there's been a significant underinvestment in infrastructure, and that's fed back into the general practice area. Now, super clinics certainly aren't a new idea. In fact, if I give you an idea of what might be in a super clinic, according to the papers that the government published, it'll give you some idea. We'll have general practice, we'll do after hours, we'll have allied health, dietitians, podiatrists, we'll have psychology, we'll have visiting specialists, we'll have practice nurses to support the GPs, we'll probably have pathology collection, dental would be nice, co-location, chronic disease management, obviously, x-ray on site would be good, a pharmacy, that would be great for the community, it'll be computerised, it'll also provide teaching. Now, ladies and gentlemen, I've just described my practice, which has been there for 21 years in Brisbane, in the city. So the idea is actually not new. It's something that's been around, and yes, it's a good model. I enjoy working there, and it's good for general practice, and we are co-located, but it is good for our patients. And I think that we have to learn from what we've got already, and learn where the pressure points are, and the places we aren't managing to actually do the best we can. What we don't have is good connection outside of our practice. I think that's what the super clinics need to do. And they do need to integrate local general practitioners, and I guess that's one of the AMA fears about the current program. It isn't going to integrate too well at this stage with outside practices, and we've heard many reports that they feel like they're being competed against, not supported by the current locations and the current model. So we need to do some modification, we need to integrate better in that area. The other area that the government was hoping that the super clinics might help was access to emergency departments. And of course, we're told that GP type patients or low acuity type patients, category 4, category 5 patients, are waiting long periods and occupying resources. Well, even if our information is that about 10% of presentations at emergency departments, but in fact occupy only about 1% of the resources. So I can give you a good example in the sense that last Monday, had a patient who had appendicitis in my general practice, and I saw him after hours at my surgery and referred him up to the hospital with what I thought was a fairly clear clinical diagnosis. He was seen quite quickly at my major city emergency department. He spent 24 hours on a bed in the emergency department with a drip, nil by mouth, waiting for a surgery. That's what's causing problems in the emergency departments. It's inpatients who should be in beds in the emergency department, not being seen, not being treated. And the super clinic model isn't going to help in that area. Certainly, if we manage chronic and complex disease better, surely we're going to unload our hospital. And I think that's true. I think we are going to do a better job if we can integrate better and use allied health professionals better. But in fact, if we're seeing our patients more comprehensively, there are concerns that have been raised that there's going to be early identification of disease and case finding. In fact, we may end up not changing the access problems to the hospital very much, because we're actually looking at our community more fully. Now, those benefits will pay off ultimately, but they may not pay off in the short term, and they certainly do highlight the need for investment in all areas of the health system, in particular infrastructure in the hospitals. And those listening will know the AMA has actually set 85% occupancy as a target to give those hospitals the flexibility to get patients out of the emergency departments. Now, one of the so the issues that we have with the model, and certainly I wouldn't like you to think that we don't welcome the investment into primary care. We certainly do, and we certainly do welcome that. We just would like to, I guess, use one of the principles of investment into any sector, and that is go and talk to those on the front lines and see what their advice would be about where the pressure points are. And I think that's what we'd like to offer the government through the AMA. Of course, implementation of this program has been more difficult. We were expecting to see 20 super clinics up and running by June 2009. Of course, we know that there's 2 operating currently, and there's probably 6 partially operating. It's very difficult to try and establish new infrastructure and get it up and running in that certain period of time. And as we know, the total focus is 31 locations, and I guess AMA is concerned that those locations aren't necessarily where the maximum pressure points are that we can do the best benefit. And as I say, one of our great concerns is that they'll be set up in opposition to existing practices. Now, we do actually need to make sure that, in fact, the AMA and the United General Practice Australia has called for more funding in general practice, but I guess our view is that we should make this funding much more broad across the board and support existing services. One of the things I did when the super clinic model was being rolled out was actually turn up to some of the public consultation meetings, and there was clear advice in the community, from the community at those meetings, that the services that the government was suggesting already existed. And certainly I can suggest to you that Redcliffe in Brisbane, GP stood up and said, but we already do this. We already provide these services, and surely this is going to compete with us, and I think that's one of our great concerns. We certainly support multidisciplinary team care within the general practice. We want to see better integration of general practice services. We support teaching and training to secure a long-term primary healthcare workforce. But who should we support in that training? And I put it to you that it's those doctors who've committed to their community, that have been in their community for 10 years plus, that both know their community well and in fact see the chronic disease and see the complex cases that are essential for teaching for the next generation. And a new service in a new location tends not to see that high acuity patient for some time and won't provide the actual benefit of the training. So I actually said to the Minister on that night that it's the grey-haired doctors, if you like, that should be focused on for training the next generation. Not quite the grey nomads, but the ones that are committed to their community and have been there for some time, who've got the clinical experience. So that's where AMA feels that investment should be put. Part of our push for more comprehensive primary care also has been general practice pharmacy. It is part of the primary care team, and we think that should be an opportunity to put into the general practices that currently exist on the ground as well. More professionals co-located in the same place can have a greater impact on benefits to the patients. And GPs and their pharmacy colleagues work very well together and have worked very well together for a long time. Now, we've got more than 7,000 general practices across the country, and we think there's significant potential to build on that strong foundation that already exists. As I say, there are many so-called super clinics already on the ground, and we need to support those services and enhance them, improve the communication. And we're talking about electronic health identifiers, and while we're all anxious about privacy and security, we must be able to communicate. We must be able to send information to each other for the benefits of the patients. And it's so important that we support that. We need to teach and to train, as I say. It's best done in those practices that have been committed to their location for some time. We should increase the number of pre-vocational exposure places in general practice as well, and give the interns and postgraduate year 1 and 2 doctors access to primary care, to general practitioners, so they can see what the ground floor looks like before they make their decisions about their future. Because we have, and I'm a general practitioner, a very exciting, interesting, very patient load, which is very rewarding. And look, we'd like to see more support for practice nurses as well within those comprehensive organisations. And we've worked with our nurses for quite some time, and they can leverage the skills of the GP, and we'd like to see that broadened and give us the ability to do that. I think there are other issues too that we can plug into this package, and that's point of care testing. We can once again co-locate that service, quickly give some feedback to patients. We can provide them with instant feedback and better outcomes. We've got to be able to order appropriate services, and some of the restrictions on MRI are artificial. Above all, I think if we support this program above all, I think we would have done it slightly different to the way the government set out, but we're certainly here prepared to actually assist them to actually making sure we get the best benefits for our population. And if we can cut the red tape for GPs, I think we can get a better outcome. Thanks very much.
Steve? Right.
Thank you. I'm going to deliver my talk today just basically as a Grassroots GP who works in South Canberra. So I've got no affiliations, although I am member of the AMA and president of my division. So I guess the question today is, are GP super clinics the answer to access problems? And my answer would say at this stage we don't know, because as Steve said, we've only got a few fully operational. And so evaluations yet to occur. And I think also we do need to note, and Steve has also mentioned this, that there are two sorts of super clinics that we need to think about. There's the government-driven super clinics, the 36 that are going to be around the country. But we also have those GP clinics that have evolved into large super clinic type practices. And what these clinics have in common is that they tend to be physically larger, include nurses and also allied health. And I think also there's areas of Australia where we actually have quite successful virtual super clinic type models, which is the hub and spoke model that Mark was talking about. So I've pretty much stuck to access as the question that I've been thinking about. And when I think of access, I think of geography, access in terms of cost, timeliness, and also who or what are we trying to access. So first of all, I want to talk about location, and I've really never got my head around the chosen location for the federally funded clinics. As Steve mentioned, Redcliffe, I'd say, look, Canberra's well known for having a GP shortage, and we didn't receive an allocation. I also really like Steve and hear concerns of GPs around the country questioning the location choice and worried about what impact a super clinic in the street down the road might actually have on their practice. And I think, of course, there's going to be negative implications if those practices are going to become non-viable, and that's obviously going to affect access. And I also think that super clinics could possibly have the potential of creating another tier of primary health care which would further fragment care, and that's certainly a concern. And I think all the Canberrans here, you can't talk about healthcare without talking about parking. And over the last couple of years, those who live in Canberra know that we've experienced the advent of the corporate practice, and we've seen a lot of smaller practices close down and doctors move into those practices. But you'll tend to find that these clinics are grouped together in large town centres, and the reason is that they're the only areas that can physically support those large buildings and also accommodate parking. So what happens? Well, in my view, those patients who really are vulnerable, and in a place like Canberra that has a fairly limited public transport system, they actually have further trouble with access because they physically actually can't get to their practices easily. They can't walk down to the local shopping centre anymore. They've got to go into a large town centre. And of course you could solve that by improving public transport, you could solve that by improving community transport, but of course that then comes with an added cost. But I think we also emphasise access in those who are vulnerable, and Mark's touched on this, that creating big impersonal health facilities can be daunting to those who actually are in most need. And I think it's also interesting to see, from my point of view, the number of Canberrans who didn't choose to follow their GPs to those large practices. They actually preferred the more personalised service that they were used to from their family GPs. And this might sound like it's Canberrans being precious, but I mean, we talk a lot about medical homes, but I think there really is a difference between a medical home and a medical house. And I think if the receptionist knows that when you say you need an urgent appointment, that you really do need an urgent appointment, then I actually think that can have positive effects on access, but actually being able to triage access appropriately. So moving on to cost and affordability, the government's brief is that their super clinics are encouraged to bulk bill to improve access, and I've heard the argument that if they could expand and subsidise infrastructure, there's an opportunity to generate income from raised extra fee, from rents that are raised, extra fee for service, and also in-house referrals to allied health and also the other GPs who might be sitting in those rooms. And you've also got economies of scale. And they're saying that basically this should offset lost income as a result of bulk billing. And I feel there's two issues here. I think from a business and quality point of view, I think the argument regarding other income offsetting bulk billing is just not sustainable into the long term. I work in a mixed breeding practice in Taiwan. We've got 14 doctors, we have 6 nurses, and we also have allied health who rent space from us. And last year, I mean, we're not a huge practice, probably not as big as Steve's, but we delivered over 50,000 episodes of care. But 2/3 of our income is actually private billed. And the rent that we receive from the allied health staff and also the income generated by practice nurses is really very negligible in the big picture. So of course, if I receive some funding for infrastructure, that may offset the reduced fee from income in the short term, but I just don't think we can sustain that in the longer term. And that's simply because, and I might sound like an AMA convert here, but I actually think that the Medicare rebate for GP and practice nurse idle numbers isn't adequate if you actually want to deliver quality care, and that means actually spending time and sorting out your patients who have comorbidities and more complex. And I also think it doesn't actually allow us to realise the full potential of the practice nurse workforce, who will definitely help in improving access. And we can't rely on Medicare rebates alone. So I think in the long term it will be interesting to see how those super clinics that have actually committed to bulk billing actually fare. And then touching on Steve's point as well, it can create an inequitable playing field in terms of fee structure, in terms of the local GPs that's close to a super clinic who haven't received that subsidy from the government, and of course that may lead to that demise. The next thing I want to talk about is timeliness in terms of access, and whether or not grouping services together will actually improve access in a timely fashion. And of course I think that depends on your definition of timeliness. So, you'll have the consumer's view of what's an adequate time frame, you'll have the health professionals' view of what's an adequate time frame in terms of health outcomes. And I think that at the end of the day, sure, it is quite convenient within my practice if we have people located under one roof, but the reality is that you might still have to wait 6 weeks to get into a psychologist because there just aren't enough of them around. So whether they're actually under my roof or down in the local shopping centre really doesn't make a huge amount of difference. However, I do think that co-location of services can mean that other team members are likely to understand the services available. And the reason I say this is that we recently surveyed Canberra GPs, and it actually revealed a lack of awareness of many health services available, within Canberra. And Canberra's a pretty small place, which in turn meant that access was being denied simply because the GP didn't actually realise that service existed and therefore didn't refer their patients to them. So I think certainly simplifying the system is going to, and actually improving awareness is going to help access. And that then brings me to my final point, and that is who and what are we trying to access in these clinics. And of course it's primary healthcare workers, but at the present stage there aren't enough of them, so all you're going to be doing is relocating them, leaving a gap from where they came. But of course, eventually we will need to to fill these centres, and I do think there's an aspect that these larger models can increase the workforce numbers, and that is basically in the flexibility that they can provide. And I'll give examples again from my own practice. One of my registrars returned to the workforce after her maternity leave due to the supervisor's supported after-hour shifts that the practice could offer her. She didn't want to work during the day because she didn't want to put her children in childcare, and we could actually get her back into the GP training programme. Similarly, our psychologists work in other jobs by day, some work in government departments, and they're able to keep up their clinical skills by consulting a few evenings a week. So for the part-time workforce in allied health, renting rooms on a casual basis has its business advantages, and this of course works well, keeping down running costs and also ensuring a source of referrals for allied health, because that's at the moment how their business model works. We need to ultimately remember that to ensure access, these clinics will need graduates to staff them, and Steve has touched on this as well. We obviously do have to increase the numbers of the primary healthcare workforce. But the plan is also that the super clinics will be centres of teaching excellence, and I disagree with Steve that you have to have grey hair to be a teacher. I don't think I have that many grey hairs yet, and I've been a supervisor for a long time. I agree that we are apparently going to have this tsunami of medical graduates, and they will need to be housed somewhere, so we do need to think about infrastructure to actually house all these people who will need training. And I do agree that, you know, multidisciplinary training, of course, is going to improve the learning experience, and it will also improve those collaborative networks, because we'll all understand one another a lot better. But I actually think it's very naive to assume that just simply by providing a nice new big building, this is actually going to increase the attraction of graduates into general practice and primary healthcare. I think it's a much more complex argument than that. And I would say regularly within the Canberra region, we see registrars move away from larger practices to some of the smaller practices that are able to deliver a more personalised teaching environment. And I think Steve had a very good point, that you'll tend to find it's those practices that have been around for a long time but actually have the pathology from which people can learn, as opposed to seeing a population of mostly under 5-year-olds with coughs and colds. And that does happen. I do acknowledge, though, that more physical space certainly can enhance teaching, and good teaching can certainly influence career choices. So I certainly think we do need to invest in our infrastructure for teaching, but I think we need to build on what we already have. And so to summarise, the concept of super clinics could have both positive and negative outcomes for access, but I think the positives are not much different than potential outcomes from a well-connected, mid-sized general practice of GPs, nurses, and regularly visiting allied health professionals in terms of access. We know that there's already an existing rich infrastructure around Australian general practice, allied health and specialist rooms, and that we do already have some collaborative networks that work very well. And I also am a true believer that new models are not always better than enhanced and pragmatic old ones, and we really do need to invest in the capacity and potential of what we already possess. Thank you.
Thanks, Rashmi. And then Russell will conclude. Thanks.
Thanks. I'd just like to start by acknowledging that we're meeting on Aboriginal land and to pay my respects to the Ngunnawal elders, past and present. I'd also like to note, as a bone marrow transplant survivor, that this is Organ Donor Awareness Week, and any of you who are not yet signed up to the register, please do so after the session. Look, super clinics are no more the answer to our healthcare needs than supermarkets are to our food and grocery needs. But they play a role, and where they can be of value is where they're physically accessible and where they have, and where they're open all hours, but they won't be of value if they crowd out all the alternatives, and they've been talked about in some detail. I was going to outline all those things, but I won't need to, so I'll cut down a little bit on the length of my presentation required accordingly. I wanted to say, though, that what consumers are looking for is safe, high quality and cost effective healthcare. The triple bottom line, if you like, of health. And with safety, we need accountability. Quality requires both access and continuity of care, amongst other things. And cost effectiveness, of course, requires affordability. And these things have been touched on elsewhere, and they are part of the mix. Super clinics can provide a different model. And this comprehensive mix of medical and allied health services could be an advantage to some groups of consumers like myself who have complex chronic conditions and need the interaction of many health service providers to keep us on the straight and narrow. But some of us will still want to continue to shop at our local corner stores, the traditional family practices, because we value some of the things that they do more than we value those other traits of the new grand scale providers. Increasingly, though, we'll want more from these boutique providers. We'll want practice nurses at all practices, electronic health records, integration with allied health services that complement the medical ones, and we'll want after-hours access. And this can be hard for really small practices to deliver without additional assistance. So the investment in super clinics is one approach to this. Super clinics can be part of an integrated health system and could have augmented services like ambulatory care clinics, outpatient clinics for people from hospitals, antenatal clinics, community nurse services tied in, as well as all of the other private services that have been talked about in the models before. And that these will extend the public-private mix of healthcare services, which we've got to be mindful of. But we know that the investment in super clinics will come at a cost. The cost is up to $10 million, as I understand, for establishing the infrastructure. And whether this is the best bang for the buck will need to be carefully evaluated, as I think Mark was talking about. So, I mentioned, though, that super clinics are part of a continuum of integrated primary healthcare services that we should be looking at. The super clinic model, the 36 or so that the government is funding, are never going to be comprehensive across the nation. The cost is just too much. And indeed, there probably isn't a need in some places. The corporate clinics were mentioned. They provide equivalent sorts of services in some way, but many of us are suspicious of the quality of service we get at a super clinic. We don't necessarily get continuity of care from the same practitioners. We perhaps get railroaded into services that are not high priority because of the vertical integration of the vertical and horizontal integration of the service providers and their drive to meet their own bottom lines. So I tend to be more in favour of the hub and spoke type models that have been spoken about, or the virtual super clinics, the ones that combine a range of providers and give more control to consumers over the providers they access for their individual healthcare needs. And I'm pleased to hear that there are already private providers moving in that direction, and some of the larger general family general practices are already providing this good mix of services, but unfortunately they're still few and far between. But the one extra element in this continuum that's only been touched on earlier is the community-controlled or cooperative model. And here in Canberra we've been lucky enough, because of circumstances probably, to have a cooperative healthcare provider start up in the west of the city this year. It's taken quite a long time to put the whole package together and for the infrastructure to be put together, but it's less than 1/10 of the cost of the sort of investment that's going into the super clinics, and I think has potential to provide equivalent or better outcomes than those that are provided with some of these grand scale super clinics. One of the reasons for this is that they're looking at whole of life, holistic care that's looking at the whole of your life problems, not just individual episodic care for medical or other specific problems. Now, having those things linked is a useful, on the one premises, is a useful thing. One of the reasons I was late this morning was that I was out receiving a primary healthcare service at Fish Week this morning. And before any of you jump to conclusions, this was a physio appointment that I was at. And that's because these services are dispersed in many ways, and it would be much more convenient to have them more closely linked. Talking to the physio, he said he was looking closely at the establishment of a super clinic in Queanbeyan and as to whether he would offer his services through that super clinic, which I thought was interesting. He asked for my advice on it, and I said I'd tell him after I'd been to the city. Just in conclusion, there are there's a need for super clinics to be seen in context. They're a step in the right direction maybe, but they need to be evaluated for cost effectiveness and supplemented by other approaches where the model is not found to be helpful in providing better access to integrated care. Above all, we need to avoid collateral damage, pressure to discontinue current effective and allied health and medical services in pursuit of innovation for its own sake. Thanks very much.
Thank you, Russell, and thank you, panel, for those decisive views and challenging, I think, thoughts. So now it's open for question. We have a roving microphone, so if you put your hand up, a microphone will find you. But could you please, two things, identify yourself, identify to whom you're referring the question, and also could you keep the microphone very close to your mouth, because we're recording this, and also the people online, of course, will need to get it through the feed. So, questions? Who's got it? Oh, thanks.
Thank
you very much. My name's Libby Calusi. I'm from the Primary Healthcare Research and Information Service in Adelaide. Always looking at sort of gaps in research and priorities for research. It seemed that both Steve and Rashmi referred to existing superclinic models which had evolved rather than being implemented in this government agenda. It seems to me that one of the gaps we have is how we find out what models there are out there. I've long been conscious that we have a lot of information about general practitioners through Medicare and through Beach. We have quite a lot of information about divisions of general practice. We have remarkably little standard information about practices, forms of practices, how they're set up, how they're located. What do you think is the best way to find this out when those personal anecdotes you've given as GPs working in these different practices are so illuminating about the way things work and the way things have evolved?
Look, I think you're absolutely right. I think that it was disturbing to see that it was a revelation to those present, those going to the public discussion meetings about superclinics, when GPs stood up and said, "Don't we already do this?" And certainly when the locations of the current 31 superclinics were chosen, there wasn't a lot of consultation with the GPs in the destinations prior to the public consultation meetings to say, well, here's an investment, where should we put it? To the AMA, it seemed rather confusing that if the model was going to work and this was to attract GPs, surely you put it where there weren't any GPs. And perhaps that's for the use of the infrastructure to actually build something that's not actually there. So I do agree, we do need to collect this information. Probably hand over to Rashmi.
Yeah, I think interestingly, for those of you who in Canberra who remember last year, the Minister had a GP task force upon which I sat. And one of the recommendations that was sort of, it wasn't particularly welcomed by the profession, was actually we do need to keep a register of what is going on in our own town, because it was quite clear that people didn't know the locations of general practices, people didn't actually know if they had open or closed books, whether how many doctors worked out of them. And so the ACT government is actually trying to introduce a efficient way of gathering that information, and I think that's still a work in progress. And although many GPs said, "Oh, it's even more work for us reporting, filling out another form," I think really for workforce planning and agendas are large as you do, and need to have that background information before you make your decisions. And clearly, I don't think that information has been collected. So interesting to see what happens in Canberra over the next couple of years.
Consumers have been asking for this for more than 10 years, Libby, here in the ACT. When the government first introduced Health First, we asked for a directory of all primary healthcare services to be made available online as an adjunct to that, and that still hasn't happened. So I agree with you, we need the information, and we need to have some way of evaluating the effectiveness of the various modes of delivery.
We'll take a question from our online audience. Thanks, Mark.
Thanks for that. We've got a question from user DTMG, who says, in the UK, business education of GPs improves resource allocation. Is that what's missing here?
Look, I don't think so. I think that you look at the evolution of general practice in Australia over the last 20 years, probably 30 years. We've had resources have been contracting, and so the cottage industry that was general practice 30 years ago has changed significantly to what it is today. And we've just discussed that we don't have good data on how many comprehensive practices there are, but the pressure of the realities of small business has meant that GPs have worked out that the economies of scale are such that if you collect together and work together, you can get better outcomes. And so from a business perspective, that's occurred because of those business imperatives. But the benefits on top of that for the patients are that services are co-located. We do share resources. Practice nurses have become affordable. And I guess what we're saying is that those models now we can look at the outcomes of those and invest in those and encourage those to sort of spread further. So it's not really the lack of business training, because we've come to this point fairly effectively without specific training in that area. And I think that all of us could run a business probably better, but it's probably not the critical success factor.
Rashmi, do you have any comment on that from
Um,
Southern Canberra perspective?
Yeah, I mean, I agree with Steve to a degree, and I think it's also you can only run your business as well as the resources that you have to run it with. And so you can certainly say that, you know, we could do things better and cheaper, but there is a bottom line, and I do think that the public don't often actually realise that we are a private business and we have on costs that are not negotiable, and we can only, and you know, we can only, and we do have assistance from the government in terms of Medicare rebates, but really at the end of the day, I think we all try, if we're running a large practice, to do things as efficiently as possible. And, you know, at the end of the day, sometimes you can only do work with what you have.
Thank you. John.
John Humphreys from Monash University in Bendigo. I want to pick up on a point that Lily's made, and even something that Rashmi said. It seems to me that super clinics, by and large, are still predicated upon a kind of market principle, that they exist in places where there's a sufficient range and threshold requirement to support them. We have in Australia something like 2.5 million people who live in communities smaller than 5,000, and super clinics are not dealing with access issues in those places. One of the AFCRI studies that we undertook, Lily, was actually to look at the service models for those communities, and we found in fact that there was some key characteristics that had to underpin the success of a viable practice model, primary care model, in any of those things. We weren't interested in a particular model type per se. We were looking to see what were the characteristics of successful models, so that, you know, things like adequate infrastructure, adequate workforce, good governance leadership, these sorts of characteristics typified all of those models, whether they were an integrated primary care, an Aboriginal community control, a hub and spoke model, or whatever. And I think it comes back to a point that Rashmi said there. I think we need to build on and emulate existing models that do work and invest in those properly. We don't necessarily have to invent something new. And I think one of the issues of access for smaller communities is not about centralising resources, it's about having access built back to the community.
Just two quick comments on that. I think the point about scaling up is one of the key issues in terms of super clinics. We've got, and this applies not just to super clinics, but all the various state government initiatives to do similar things, and even the work that's going on in the private sector that's emerging as we get larger centres. We really need to think about what are the implications of this in terms of access for the entire population, and how are we going to scale up this sort of operation in a way that's equitable. And we've heard about equity in terms of the other GPs that might be around, might be disadvantaged by super clinics. But the other kind of equity is in terms of ensuring that, and probably from a government point of view, the most important sort of equity is in terms of consumer access to those services. So if we're providing something that's better in super clinics, then how does the rest of the population access those things, particularly people from low socioeconomic groups?
I would add to those comments and just say that clearly there does need to be a variation in the model. I mean, the themes certainly is better communication, better coordination, better integration of services. But you do point out, but you quite rightly point out that there are locations that won't sustain a large piece of infrastructure in one location. And so those models need to be supported, explored and encouraged. And IT and virtual hub and spoke models may be better in that area. We've also got to remember that it's not just internal factors which are relevant in those locations, it's actually external factors. It's actually spouse employment, child education, future opportunities, professional development opportunities, and all of those things influence the availability of workforce in smaller locations. And those things have got to be simultaneously solved to make sure we have a well-supported workforce in smaller areas, in perhaps more rural areas.
Russell?
Yeah, I was just going to draw on the supermarket analogy a bit more and how that applies in rural areas. Maybe we need to be looking at mixed businesses in some of those rural areas where there might not be a single provider, but you can have a range of services that are coordinated by somebody who is resident in the town all the time. So you would, it's like the visiting specialist model, I suppose, that you would have a pharmacy maybe as an adjunct to another business in town rather than a standalone pharmacy, because there are rules around how big a catchment you've got to have before you can establish a pharmacy. That denies people access to that service. So similarly with the medical and allied health services, if they're seen as add-ons to something that already exists, rather than as standalone private enterprises, they might work better.
Thank you. Martin, you have another question? But you don't have a microphone.
Okay, another question from online. Sorry about the delay there, folks. This user has asked, why are GPs not investing in general practice when listed companies are? And should we be encouraging practice ownership? Because surely owning your own home is better than renting it. You'll get more commitment from people.
Well, I think that we've heard about the shrinking resources in general practice. We've heard about the necessity for economies of scale. We've got a changing workforce in general practice as well. We've got an ageing of the workforce, and again, we're getting a lot of new graduates coming in with different views who want to practice their art of medicine, and may not necessarily want to be business owners. Certainly, business ownership does focus the mind on outcomes. But there is the opportunity for many practitioners now to work in general practice and focus on the patient in front of them. So I think there's a variation and a change in the way that there are attitudes of our workforce. I think there's a balance. I don't think you'll see business ownership go away, but on the other hand, there's the opportunity to work and focus on your patient in front of you.
Can I also add, I've got a practice with a large number of Generation Y trainees and doctors, and Generation Y, definitely Generation X, and they have a much better work-life balance than I think their predecessors, and good on them for doing that. But I think also in terms of, why don't we invest more? I mean, I think as a business owner, yes, I do, and no, I didn't buy a premises, because in a place like Canberra, if I buy premises, I have a lease that says it can only be used for X, Y, Z, and so in 10 years' time, when I get sick and I want to retire from the workplace, I'm lumbered with this investment that I can't do anything with. And so I think you've got to realise that it's not as simple as just saying, oh, just go and buy that shopping centre and open your own practice. It's actually extremely complex and something that a lot of people look at, but then have to weigh up their whole life-work balance decision before they actually go into something that big.
Thank you. Right, we have time for one more question. Ellen.
Thank you.
Oh, sorry, two more questions.
Ellen McIntyre from the Primary Healthcare Research and Information Service. Mark, I just want to pick up on a couple of things you said, and also that were reinforced by Russell. The fact that the super clinics is probably more an experiment, because there's more we don't know than what we do know about how well they'll be conducted. And Russell, you also mentioned that it's really important to evaluate as we go. And Mark, I'm just wondering, what would you suggest in terms of evaluating and monitoring and researching this new experiment, or not so new perhaps, so that we don't end up with a future with super clinics that we don't understand and we wish we'd done better, and if only we'd done it this way right from the beginning. So I'm looking at what sort of infrastructure is required, what sort of support is required, just to make sure that what we are doing will continue to be monitored and we can improve on as we go along.
Well, very quickly, I think there's we've got a variety of models, including non-super clinic models in private sector and in public sector. And I think there's a desperate need for those to be evaluated. Obviously, there's very different ways that they can be evaluated. We need to know more about, at this stage, what they're doing and how they're performing at a very basic level. What kind of services are being offered, what sort of patients are accessing them, and so on. A lot of that should be available through Medicare if it was made available. Unfortunately, it's quite difficult to get access to that kind of Medicare data to do that sort of research. Resource-wise, I think a few, it would require some strategic research to be done, but it's not a major exercise. What concerns me is that I'm not aware, either at Commonwealth or state level, of any kind of systematic attempt to evaluate this, and we really do need to know the answers to some of these questions if we are going to scale this up.
And can I put in a plea for involving the consumer community in that evaluation? There are already some surveys that are going around the rounds at the moment that are developing consumer experience within a range of primary care settings, and somebody needs to collect that data and analyse it and set future policy direction on the basis of that.
Okay, thanks. Now, final question here from Mark.
Mark Medal, Sydney Morning Herald. Just following up, Mark, on your comments about allied health and the lack of Medicare coverage for many of their services. What has been the experience so far? Is everybody going through the enhanced primary care mode? For most of the people getting the allied health, the physio or the psychology, do you know? Are gaps showing up? Because it seems funny, on the one hand the government's saying, oh, we hope they all bulk bill. Well, that's right for the medical service, but what about presumably up to half of the services likely to be provided are allied health, and is this a great gap in the arrangement?
Well, I think we've got all sorts of gaps in terms of allied health. First of all, only certain people actually get through the process, so you've got to have a care plan to get in, and there are allied health services that are appropriate for people who don't yet have a care plan. But secondly, I think there's issues about the extent to which consumers actually have to pay extra, even for the services that are funded under Medicare, and the degree to which that acts as a disincentive. Patients often, particularly if they've got to go to see a provider in another place, may be quite ambivalent about going to see a psychologist or a dietitian, for example. And if they've got to pay out of their own pockets on top of that a significant amount, then that's a problem. And that's certainly the case that most, that in Sydney, for example, in the eastern suburbs, if you refer to an allied health provider, that's very likely to come with a copayment. And that can be quite significant for someone if they've got to pay an extra $10, $20, $30 each time they see the allied health provider, on top of all their other costs.
I guess just to add, there's a fair bit of red tape that is between the decision to refer and the referral, in that if you look at clinical need and people with chronic conditions that need a structured approach to healthcare, that gets you a GP management plan until you get through the team care arrangement. In other words, you've got chronic and complex care that requires at least two other individuals to intercommunicate. The bar is set quite high on the red tape. So getting access to people on the basis of clinical need for lesser acuity issues would streamline the process. But of course the financial access issue at the other end is the last one.
Okay, well look, thank you. Then we'll draw to a close there. I'd like you to join with me again in thanking the panel. Before we finish, I'd like to give a plug for this series. This is a bit like planning a Star Wars series of movies. We've decided roughly 6 episodes, and we haven't quite worked out what each one will be, because it's a moving target. For example, there's very strong rumours that the government's going to make a major announcement on health reform this week or next week or the week after or very soon, which could be any time between now and Christmas, I guess. But so we will try and keep these series topical, but we do want to look at further issues around primary health care, particularly perhaps around the governance of primary health care, and also questions around funding the system. And we also want to look at some of the questions that we think haven't even been asked in the health reform process, or certainly haven't been answered. So that you have to bear with us around that. But our next event will be in April, and will be probably to do with the issues of governance, but we haven't quite finalised how that will work. So watch this space. The other point I'd like to make is, some of you might have been wondering why we didn't have a government spokesman or spokesperson here to speak on behalf of the government. That's a conscious decision we've made in this series not to have government people, because well, they can speak for themselves, and they get plenty of opportunity. This is a chance to bring evidence and different perspectives on the issues we're raising, rather than get the the official line, as it were. So again, I'd like to thank you all. I'd like to thank those who have joined us online, and we hope to see you again in a month or so's time. Thank you very much.